The next candidate, my friends.
Yes, I'm here.
Okay, let's see. Severe headache.
Okay.
Okay, let's see. Proceed يا boss.
Okay, I'm presented with MRI.
I will choose this one first. I'm sorry. Okay.
Okay, no problem. I've been presented with an MRI T2 sequence of patient complaining of headache, old age. I'll scroll through the sections from to bottom to check for any gross abnormality. Can you scroll down, please? Little bit slowly. Severe headache. Yes, I'm trying to spot any. Uh,
Okay. A general
okay.
question. A general question. In
Yes.
normal appearing MRI, I think we discussed in a normal appearing CT brain, we should
Yes.
assess any subtle hypertenesis like subarachnoid blood,
Yes.
whether cortical or
Yes.
in the sister,
Sequel.
like
Uh,
cortical vein thrombosis or dural sinus thrombosis, like hyperdense vessel sign, like cavernomas, any subtle hypertenesis, and also some
yes.
hidden areas. In
Yes.
MRI, I'm looking for hidden areas. Like what?
I'm looking at the like for example the venous sinuses, the suprasellar region, also in the orbit in the brain,
Good.
like cisterns, any vascular abnormality if I can
Very good.
spot something like this. I'm trying to check for the vessels here in the region of the internal carotid. I am trying to spot for any also in the if any like basal cistern and the foramen magnum. I'm trying to spot if there is any crowding present or something
Good.
like this.
Good. Yes, this is a start point, my friends. It's very
Yes,
common, a very common hidden case in the exam. The medulla and the craniocervical junction should be encircled by CSF. Okay,
yes. I think there
cerebellar
is little bit
tonsil should be at higher level. Very
crowding.
good. Not
Yes, yes.
crowding, not
So
crowding in this case.
not
Good.
crowding, but not
Okay.
crowded. Okay, so and I
So
think there is
nothing.
some
Hmm.
nothing till now. So I could check for any other sequence, for example, T1 and sagittal and the multiplannar images
Okay, I'll
in the
give
coronal
you
or
a
sagittal.
T, yes, but generally in T2 with acute insult, look for any dark signal. Generally, look
Yes,
for
yes.
any
To
dark
preclude
signal.
any bleed, for example,
Yes, yes. The opposite
hypernomas
will
or
be on T1. Okay, let's
yes.
see.
I have been presented with T1 images of same patient. Yes, there is. I think there is in the at the region of the pituitary
Good.
gland, there is area of high signal intensity at the epicenter, I think, on the pituitary gland, and
Good.
it appears enlarged and some minimal mass effect upon
Good.
the internal carotids.
Good.
So I'm thinking this could be a pituitary gland lesion with this bright signal should be referred correlated with T2 weighted images if it's hyper on both sides. So I suspect it's acute bleed on a pre-existing pituitary lesion. Yes, there is some
Yes. And here,
hyper
here
intense signal noted
from the
here.
T2, this is definitely
Yes,
abnormal pituitary gland,
yes,
hidden
yes,
area,
yes, and
hidden
also there is
area.
some perioptic nerve. There is many some edema on both optic nerves. Maybe,
You can ignore
maybe
it.
it's
No, no,
a
you can
subtle,
ignore it.
not
Okay.
normal or ignored. Yes.
You can ignore
So
it.
in
Yes.
my yes, in
Mm.
my routine practice, considering the age of this patient, I'm suspecting this could be a pituitary lesion, probably macroadenoma. I should compare this with any previous imaging, any clinical data that could say
Okay. So macroadenoma. What about the hyperdensity, hyperintensity, reflecting what?
hemorrhage, pituitary
So
apoplexy,
maybe
maybe
hemorrhagic
hemorrhagic.
macroadenoma. With
Yes,
this
that's I was
age
going to.
group, anything else in the differential?
Yes, it could also maybe metastasis in that region, meningeal, but I think it's less likely. Also,
Less
maybe
likely metastasis. Okay.
because it's yes, yeah, but
Because
I'm
what?
going for because there is a lack of multiplicity only in this area, and there is no significant mass effect in such region.
Okay. Okay. Actually, the patient came after a couple of days, okay,
Yes.
with deterioration of the condition.
Mm.
Let's see this sequence and tell me what happened.
Yes, I think the same region. I think the lesion all more or less is not a little bit enlarged. I think the same
Okay.
size,
Maybe
but
some resolution of
some
the
resolution.
hemorrhage. Good.
Yes,
But the
but
patient
I think
clinical
then
is deteriorated.
yes, yes. I want to check for the any developing like vascular compromise or any. I should yes, there is a hyperintense signal noted here in the both yes both posterior parietal lesions, mainly
Good.
subcortical.
Good.
So and also another area here in the left frontal.
Good.
So I think this could this
Mm.
hyperintense signal could be either fatty signal or either could be blood signal. I shall compare it on the T2 weighted images.
Okay,
Um,
why you
okay.
put fat, yeah, boss? Why you put
I thought
blood is
maybe
okay.
blood is okay. I put
Okay.
it as differential if there is any associated
So,
dermoid rupture, but I think
but
it's
I
away from our context. Yes, yes.
good,
Sorry,
good, good. Say
sorry.
blood first. Blood first, Allah
Yes,
يكرمك.
yes.
Okay.
Blood. Sorry,
Okay.
sorry.
Any other sequence that may help? Because
Blooming.
T1,
SWI.
T2 is
SWI.
in remark. Good.
SWI.
Okay.
SWI.
Here in T2, it doesn't help
Too
much.
much.
So
Yes.
SWI. Oh.
Okay, massive. So this case of multiple blooming artifact scattered all over almost of the cerebral hemispheres, more at the post-parietal regions, or more mainly more cortical and the lobar predominance, and also at seen at the basal ganglia. So my differential in this case, we have the most likely,
Mm.
if we consider the pituitary lesion is a neoplastic, this could be if the patient had radiotherapy, same as the previous case, this could be uh, cavernomas, but least likely to develop too much cavernoma in such short
Slightly,
duration. The other
yes.
different,
Mhm.
the more conspicuous one would be cerebral amyloid angiopathy in such a
Good.
presentation.
Which, what is the
Uh,
distribution
ha-
of amyloid?
it's lobar. It's mainly lobar, cortical
So
based.
this one
So
doesn't
this,
explain the amyloid. Very good. Other
yes,
differential,
yes. Other differential maybe most likely
if the patient is
hypertensive, but
hypertensive,
yes, but my hypertensive will be more at the central
basal
basal
ganglia,
ganglionic
but
region. Yeah,
it doesn't
but
explain this. Okay.
yes. So
No problem.
maybe
Yeah. We are talking
I'm trying
discussion.
to
Okay.
maybe yes, no, it's fine. I'm trying also to make up what could present so much.
Good,
If,
good. يعني till now, as a patient has a
mm,
CT, and as you see, it's multiple large hyperdense
yes, yes. So
foci.
also
Okay.
maybe may also be dealing with this previous case as hereditary cavernomas we saw it before,
Uh,
but less likely.
remember
It's
the first look.
first
You
the
said
study
you
didn't
said
show this.
you said
Yes, yes,
macroadenoma versus,
metastasis.
okay, what type of metastasis that send hyperdense and
Hemorrhagic
blooming,
one. Yes, melanoma,
especially
renal cell carcinoma, thyroid,
melanoma.
melanoma.
Melanoma. Okay, you
Okay,
said less
okay.
likely. Okay, it may centered upon the pituitary. Okay,
Yes, yes. But
about
as a problem that I noted only in one side, that's why
no problem,
I less
no
likely omitted it.
problem, no problem. We are revising here. Okay, thank
Thank
you,
you, Dr.
Yabus.
Ismail.
Thank you,
Jazakallah
thank you.
khair. Thank you.
Like
Thank you.
okay, my friends, let's revise this item. It's very important in practice and in exam. What are the lesions or structures that can be associated with a blooming artifact? Okay, if especially if multiple, multiple cavernomas, usually the history will be mild, age group will be younger age group. It can be just focus or multiple foci of a hyperdensity on a CT scan. MRI can be helpful if you see a hemosiderin rim or classic popcorn sign, which may necessitate SWI. Hypertensive hemorrhage, it will be centered upon the basal ganglia, usually elderly person. Amyloid angiopathy, again, elderly person, but normotensive, and usually scattered along the periphery, sparing, relative sparing of is this one, relative sparing of basal ganglia, and it can be associated with either microbleed or gross lobar hemorrhage. Also, a hypertensive can be associated with microbleed or gross basal ganglia hemorrhage. Okay, so these two groups in old patient. Of course, diffuse axonal injury, it's a trauma. And remember, trauma, but maybe normal appearing CT scan, or let's say unremarkable. Okay, unremarkable. But and also MRI, maybe just unremarkable. Remember the grading of diffuse axonal injury. It starts at the gray-white matter, then corpus callosum, then basal ganglia, very poor prognosis, very low Glasgow coma scale. Okay, my friends, it's important if you face a case of diffuse axonal injury in the exam and you suspected diffuse axonal injury, say the pertinent negative, okay, which is I see some foci at the gray white matter interface, no foci at the no hyperdense foci at the area of corpus callosum. And remember, corpus callosum, the bleeding can be at the geno, at the splenium, or higher up at the body, in the center of the image at higher up. Okay, any one of these, of course, later on, it can cause superficial siderosis. Other causes like metastasis. If the patient has a fracture in the lower limb, it can cause fat emboli. Fat or air embolism can also induce pluming artifacts. Okay. Okay. About yes, this question. If you want to differentiate between blood and calcium, we can use a phase contrast study. Okay, and try to follow the signal of blood vessel. Okay, if the blood vessel is dark, I'm expecting all blooming structures will be hemorrhagic. If the blood is bright, the same. All blooming will be calcium, the reverse of blood. So it can be bright, it can be dark according to the machine. According to the machine, we have something called right-sided machines, like GE, left-sided machines like Siemens. So the signal will be the opposite. Okay. Myeloid sub. Yes, yes, yes. Amyloid prefer the periphery. Hypertensive prefer the center. So amyloid, subcortical, okay, lobar mainly, and hypertensive basal ganglia mainly. Okay, my friends. The next candidate يا boss.
السلام عليكم sir.
عليكم السلام ورحمة الله وبركاته. Let's revise anything I wrote it wrong here. Sorry. Yes, yes, my friends, I will reverse this. Very good, very good. Only one who noticed? Yes. Okay. Excellent, يا boss. Excellent. Yes. Amyloid periphery, spare basal ganglia. Hypertensive involve the basal ganglia. Excellent, my friend. Okay. Dysarthria, upper limb. Again, we have something like suspected stroke. Thank you, candidate
Okay.
4. But young age group. What do you see?
Okay. I'm presented with CT brain axial non-contrast. I'm scrolling through the images, then I will start commenting on my findings. In this, I can see ventricular system appears normal. Gray-white matter differentiation is preserved.
Good,
Scrolling till the last cut. No area of abnormal hypo or hyperdensity seen.
good,
Alvarium appears unremarkable.
good.
No
In
mass effect.
a female middle age, what you are
Yeah.
looking for?
Yeah, I'm looking for the occipital region for
Good.
any
Excellent.
hypodensity. Looking at the occipital lobes, there is
Why hypodensity in the occipital lobes?
can be posterior reversible encephalopathic
Yes,
syndrome.
excellent. Especially if preeclampsia, postpartum
Yeah,
states. Excellent, excellent.
yeah,
What
yeah.
else?
What else? I'm looking at the pituitary for any lesion.
Yes, like Sheehan syndrome. Excellent, excellent. Also related to pregnancy. What else?
Looking at brain stem and ventricular system. So far, I couldn't find any significant hypo or hyperdense lesion.
So back
Looking at
again
the
to
vessels,
middle
yeah,
age, yes, middle age lady, and for example, postpartum. If hypertensive, okay, it may يعني cause press.
okay.
What
I can
if,
see in left cortical uh,
yes,
hyperdensity seen. Yeah, left cortical vein which appears hyperdense.
good.
Looking at the other venous sinuses for any
Yes,
thrombosis.
hypercoagulable status. Yes, pregnancy cause
Yeah, yeah,
hypercoagulable
yeah,
status. Look,
yeah,
definitely you should assess and tell the examiner, I'm looking for the venous sinus, not just the vessels, the venous
yeah,
sinuses. Okay, you noticed abnormality. Complete.
yeah. Okay, and superior sagittal sinus also hyperdense in the vertex.
Normal
Mild.
density. Okay,
Yeah.
normal density. Okay, and normal
So,
size as well. Okay,
yeah, but no significant hemorrhage or infarct is seen in the
excellent.
visualized brain parenchyma. So I will do CTV or MRV of this patient for further evaluation of all the venous sinuses
Mm,
and veins,
Good,
deep
good.
and superficial
Uh,
veins.
I agree. You told me no hemorrhage. I agree,
Yeah,
but no
yeah.
infarction. Are you sure? Are you sure?
Yeah, there's mild cortical hypodensity seen.
Yes. You see here
Yeah, yeah,
by
yeah.
comparison, there is
Near
related,
vertex.
yes,
Yeah,
underlying hypodensity that may reach the cortex. Is this
yeah.
arterial territory?
No,
Definitely no.
yeah,
So it follows the venous territory. What could be this
yeah.
one, my friend?
This is
Mm,
superficial cortical vein causing infarct.
yes. Yes, it's a dense cortical vein sign. So
Yes.
dense vessel sign can occur in the artery. Okay, like
Okay.
middle cerebral here, dense vessel sign here can be what?
Basilar tip can be dense
Basilar
here.
tip, and here posterior
Yeah.
cerebral, posterior cerebral.
Suicidal.
Okay, and even dense vessel sign here can be anterior cerebral. Anyone of the
Yeah.
arterial system, and it can affect the proximal segments or even cortical segments. Okay,
Yeah.
very good. This is the arterial, but this one is a venous. Okay, so
Venous.
you suspected early venous infarction. What we will
Yeah.
do next?
I
Venography.
will do, yeah, venography.
You asked for
Okay.
venography. It was
Yeah.
unremarkable. What is the next?
I will do MRI,
Yes,
DWI images to see infarct
excellent,
and also
excellent.
do MRV images.
Okay, yes. Now,
Okay. So here I can see on T2 weighted images there is hyperintensity in the forementioned area in the superficial part of near vertex on left side with associated dense cortical vein
very good.
suggesting
Uh,
infarct
uh, not
in
dense, but
left high
yes. Okay,
parietal
and
region.
uh, what is the next sequence? T1. Why?
Yeah, I will see if there's any hemorrhage because venous
Good.
infarct are associated with hemorrhages. So
Excellent,
any
excellent.
hyperintensity, no hyperintensity seen in these images. So
Good.
this is infarct. I will compare on DWI for any
And
restriction and
oh,
CMRV images.
okay. So DWI, yes, we
Yes,
have a
there is a
cortical.
restriction compared with
Good.
ADC. Yeah,
Then the next one, the next sequence
yeah,
is
ADC, ADC.
okay, and ADC it's corresponding. The next
Okay,
sequence is
MRV,
before MRV.
uh,
T1 was
perfusion.
normal. Are you sure no
Yeah,
hemorrhage?
flare images will confirm if there is any hemorrhage or
Flare or
SWI images.
SWI? Okay.
SWI,
SWI.
SWI.
Definitely
Yeah,
SWI. Okay.
yeah, yeah.
Okay.
SWI.
So it was, I think, no hemorrhage. What about this blooming?
This is cortical vein thrombosis
Yes, the
causing
cortical vein
fluid.
itself. Okay. But
Yeah, yeah,
no significant blooming in this area. Very good,
yeah.
my friend. So your diagnosis is
Cortical vein thrombosis causing left high parietal infarct.
Yes, very good, my friend.
I
Very
will
good. And
immediately refer this patient to neurosurgery and advise anticoagulation start.
excellent. Anticoagulant. It doesn't necessitate any intervention. Very
Yeah.
good, my friend. Thank you. And it's a good discussion about the etiologies in a middle-aged female. Think
Thank
about
you, sir.
breasts. Think about dural sinus thrombosis. Cortical vein thrombosis, like the previous vein, it's called vein of Troland. Okay. By the way, just to Right. Vein of Troland, okay, is a cortical vein that drain into superior sagittal sinus. But if we see another cortical vein at the temporal lobe draining into the transverse sinus, it may be vein of, you remember the name?
Vein of Leb.
Above, vein of Lepi. Excellent,
Yeah.
excellent. Very good. So above Troland and below Lepi. Okay. And remember, my friends, uh, if there is an infarction doesn't follow the arterial territory, it may be venous. Venous infarctions follow. Yes, we have venous territories as well. Okay, especially if the infarction is bilateral. Bilateral thalamic infarction. Look at the internal cerebral veins. Bilateral parasagittal infarctions. Look at the superior sagittal sinus. Atypical temporal infarction, it can be related to transverse sinus or the cortical veins. Excellent, excellent, my friend. Okay, Dr. Ali, we have another candidate.
Yes, we have candidate number 6.
Good
Okay,
afternoon, sir.
how are you, my friend?
Not too bad. How are you?
Alhamdulillah, Alhamdulillah. Okay. Severe headache. Oh, thunderclap headache. This is a
Right.
classic. Whenever you hear this word, severe headache, think of what?
So, in a young patient, middle-aged patient, aneurysmal rupture and
Excellent,
subarachnoid hemorrhage.
excellent. Especially if non-traumatic. Excellent. Okay.
Okay. So, so this is a axial CT slices, which are non-contrast, and I can see that the gray white matter is preserved and there is no normal appearances of the sulci and gyri. There is hyperdensity along the tentorium, posterior tentorium, and
Are
the
you sure? Where?
just about
This is a
here.
junction. No, this is a normal thickness. Even
Okay,
if it appears hyperdense, what about the thickness? If a normal thickness, it's a normal
it's
dural
normal.
reflection in the lower
Okay,
part of the falx and the upper part of the tentorium. And they
okay,
always compare right and left if you suspect. If
okay,
you suspect also, you can do a reformatted image, sagittal or coronal. Okay, what
okay.
else?
So
Because
there,
in this young age,
mm,
I'm discussing with you. In this
mm,
young age, dural hemorrhage is subdural hematoma. If hematoma in the falx or tentorium, it's definitely subdural. Unlikely in young age. Okay,
yes, yes.
subdural can be common in old age, but not in this age, and doesn't cause severe headache. Usually fainting. Okay,
Okay,
okay.
okay. So so there is
Hmm,
no tonsillar herniation. However, there is
good.
some, there is effacement of the fourth ventricle and hypoattenuation around. So it is a patchy hypoattenuation around the cerebellar
Oh,
peduncle.
okay, you
Um,
can ignore it. Some artifacts occur يعني multiple times at the posterior fossa. I'm the examiner. I'm telling you, ignore it. Look
okay,
above. Okay.
okay. So right.
Severe headache.
Severe
From the
headache.
start, you are looking for what? Severe headache, thunderclap headache,
So aneurysm.
or subarachnoid hemorrhage that may be related to aneurysm or non-aneurysm. What are
Okay.
the locations for subarachnoid hemorrhage? It's a hidden case.
Okay, so if it is in the perimesencephalic cistern, then it will be in the higher up. The aneurysmal bleed can be in the MCA or ICA territory. Um,
I will answer later. Okay.
Okay, so
Cortical sulci looks fine, so no subarachnoid above.
no, sort of
Subarachnoid smearing the sulci usually post-traumatic. Look at the basal cisterns. You may find subarachnoid related to the aneurysm rupture. If not, look at a specific area for a subarachnoid. We have three main types of subarachnoids. That one related to trauma. Look at, just a minute, my friend, here. Look at the cortical sulci if related to trauma. If related to aneurysm rupture, look at the basal cisterns, especially Sylvan fissure, interhemispheric fissure. And the third one, non-aneurysmal. Where to look for non-aneurysmal subarachnoid?
perimesencephalic
Okay,
cistern.
look at it.
Yeah.
Where is the
It's like
interpeduncular cistern? Where is it?
there is
This
a
young
high
patient. I should see the
density.
CSF. Yes, you
Mm,
see, hidden.
okay. Mm.
Okay, describe it, my friend.
So there is a hyperdensity in the interpeduncular cistern and
Good.
possibly in the ambient cistern as well.
Excellent.
And so
Even lower down, close to the prepontine cistern. Yes.
yes,
You see?
yes,
Show me.
prepontine cistern.
Yes. Yes.
Oh, sorry.
Yes.
Just
This
there.
area, this
Yes.
hyperdense transverse area is not normal. Here, I should see only one dot related to the basilar artery.
Mm.
But I see a broad area of hyperdensity if facing the prepontine cistern and also part of the prepontine cistern and interpeduncular and ambient. So, pertinent negative. What is your diagnosis first and what is pertinent negative?
So there is a perimesencephalic subarachnoid hemorrhage,
Excellent.
and I do not see any large intraparenchymal hemorrhage or hemorrhage extending into the basal cisterns. So
Other basal cisterns, oh good.
other basal cisterns, yes.
Good.
So I would be concerned about the cause will be non-arterial, which would be in this case will be from the veins.
How to be sure?
So CT angiogram.
Yes, definitely. The next study will be CT angio. But before CT angio, my friends, if you're suspecting, I'm the one who control now. If you're suspecting a subarachnoid hemorrhage related to this area, just to revise, I will take the control, then I'll give it to you again. Okay, my friend? Okay. In this area, my friend, you see hyperdensity and effacement of the cistern. We have three cisterns here: the interpeduncular, the ambient, and the quadrigeminal. All this region considered perimesencephalic. Perimesencephalic hemorrhage is a type of hemorrhage of subarachnoid. If it is limited to this area, it's okay. So pertinent negative, is it extending along the Sylvan fissure? Is it extending along the interhemispheric fissure or interventricular? Less likely interparenchymal. You said no interparenchymal. This is good point. But another good point, other spaces, especially Sylvian, interhemispheric, and intraventricular. Why? I'll tell you in a minute. Now, my friends, do you see any aneurysm? Because you are looking for aneurysm. Do you see any aneurysm?
No, no aneurysm.
Good. And sometimes you see small caliper of the basilar. Why?
Vasospasm because of the bleed.
Excellent. Vasospasm. Yes. So if you see no aneurysms, what is your diagnosis and what is the next step?
Perimesencephalic subarachnoid hemorrhage secondary to rupture of the small veins in this region.
Excellent. Yes. Here in this region, my friends, if you see in a non-contrast study, I will answer the question of our friend. If you see the hemorrhage accumulated in this area, this is called the perimesencephalic as a location. Okay, no contrast pooling elsewhere. No contrast pooling along the expected sites of aneurysms. Okay, like what? Like middle cerebral and like anterior cerebral. But here maybe aneurysm related to the basilar artery. Yes. Suspect. This may represent perimesencephalic hemorrhage, which can be non-aneurysmal in more than 95%. But to be sure, I want to do a CT angiography. What is the next step, my friend? Negative CT angiogram.
So a negative CT angiogram does exclude aneurysm and its rupture. So patient does not need any neurosurgical intervention, but if there is still a clinical query of aneurysm, then a digital subtraction angiography can be.
Excellent, excellent. Here, another protocol that follow up after 10 days or 2 weeks, it's complete resolution. So after a negative CT angiogram, according to local protocol, we may do a follow-up CT scan or a conventional. When to do a conventional digital subtraction? If the hemorrhage extended to the distal aspect or peripheral aspect of sylvian, or the distal aspect also of interhemispheric fissure. So it perimesencephalic but extensive. In such case, even if negative CT angio, we may proceed to a conventional angio. Thank you, my friend. Well
Thank
done.
you so
Well
much.
done, Yabas. Well done. Okay, Dr. Ali, finished or remaining anyone?
We are finished, yes.
Okay, Alhamdulillah, Alhamdulillah. Okay, thank you, my friends. I hope this session will be beneficial for you. Inshallah, I'll meet you next week, Sunday, Monday, the same time for a group of